Please welcome our first guest, speaker Dr. Marie Westby. Her topic, hip and knee replacements in Canada. What does quality rehabilitation look like? Dr. Westby?
Great, thank you. Oh, it does work, just like that, a miracle. So thank you. It's a pleasure to be here this morning and to share with you some of the work that I've been doing over the last couple of years on examining the quality of rehabilitation care for people who are undergoing hip or knee replacement. So this morning I'm going to just briefly talk about what is quality care, what are quality indicators that we talk about in terms of a metric or looking at the value of care we receive as patients, how are they used, and what are some of the quality indicators that are emerging through the process that we're undertaking that reflect the optimal quality of care that someone should experience when they're having a hip or knee replacement. And I'll be focusing on hip or knee replacement primarily for osteoarthritis. The needs of people with inflammatory arthritis are much greater with their multiple joint. Often a single joint replacement is one of many joints that are involved. And their experiences do differ, and we learned that in previous work where their needs are different. So hopefully this research evolves into also addressing their needs. So what are quality indicators? Basically, they're a standardized measure that defines a minimal acceptable standard of care. It's what everyone should expect to receive at bare minimum across Canada when they are contemplating and undergoing a hip or knee replacement with regards to the rehabilitation. So not necessarily the surgical procedures or the medical care, but the rehabilitation care. They can reflect care processes. Processes are things like the type of services your physiotherapist might actually give you, the type of education you receive. They can reflect structures of care, such as one of the indicators I'm going to show you is whether or not there's a dedicated ward or dedicated and experienced clinicians who have experience in total joint arthroplasty. So that's resources and personnel that are available. And they can also reflect outcomes of care. And that's a tough one to actually develop because all of these indicators have to be within the control of the healthcare system or the provider. It can't be out of their ability to control it, otherwise it's not really fair to measure it. So the outcome ones are challenging. Quality indicators are developed ideally from high quality evidence that's already published. So these are things like systematic reviews where they've synthesized large bodies of evidence and pulled together only the highest quality evidence, or practice guidelines that already exist. In this area of hip and knee arthroplasty, there's very little in terms of synthesized or high quality practice guidelines or systematic review. So we've had to do a lot of that ourselves. I've put together an 18-member panel from across Canada, and on that panel sits patients who've undergone a hip or knee replacement, orthopedic surgeons, physical therapists, occupational therapists, nurses, family physicians, to get a real varied perspective on what does quality of care look like. And what they've done, and I'm going to share some of the early results with you, is rate and discuss 81 proposed indicators for quality of care. I was hoping it might be smaller, but it's a large scope, and we're encompassing both the pre-op phase from the time you're put on the waiting list, which in Canada is a nice long opportunity for rehab, right through the acute care stay, which is a very short period of time, up to 1 year post-op. So it almost spans 2 years, and that's why there's so many indicators. There's 42 that have been proposed for total knee arthroplasty and 39 for total hip arthroplasty. And those quality indicators that are rated by this panel the highest for both importance, and that means it truly does reflect a high quality of care, and validity. And validity reflects, is it scientifically sound? Is there good evidence really to support this statement? Those ones will go through to the final set. So how are quality indicators used? Clinicians, myself as a physical therapist, can use them to implement best practices. So where there are guidelines and recommendations for care, these quality indicators are a nice bridge to help me put those into practice. They should and can inform clinical decision-making and share decision-making with patients. They help us plan our treatment and assess whether or not we carried out a treatment as per the quality indicator, and to evaluate whether our interventions were effective. Managers, oops. See if it works on this one. Oh, that's a tiny little dot. There we go. Managers or decision makers can use quality indicators to monitor the services or outcomes of their department or service that they offer. They can compare that across settings. Quite often a manager is responsible for all the services within a health authority, and they can look at whether one service is performing better with regards to these quality indicators than another, and then look at, why is that? What's enabling one facility to do better than another? And if there are these gaps or inconsistencies in care, then that can guide some what we call quality improvement efforts. How can patients or you use them? You can use them to make your own informed decisions about the healthcare options. Where you have choices in the system when it relates to hip and knee arthroplasty, you can use these metrics to make decisions around the providers that you might want to work with, such as private practice therapists. What programs are better meet these quality indicators than another. So sometimes you have choices and options. And monitor their own quality of care and provide feedback on what you're receiving with regards to rehabilitation. So let's look at them. We have divided the quality indicators into pre-op, that almost 1 year in some cases before surgery, the acute care phase, the post-acute, that 1 year afterwards, and then also we have 3 quality indicators that span the whole continuum. They should be applied in all stages of care. So maybe I'll show on this one. This is an example of a quality indicator statement, pretty wordy, but this is a scientific way of how it's formatted, and these will be modified depending on the audience, whether it's for patients or clinicians. So it's based on a method in the United States called the RAND, UCLA method in University of California in Los Angeles. And you say a statement, so if a patient is undergoing a total hip replacement, if a patient has cardiovascular disease and has this sort of blood test, then a certain type of care or process needs to occur. What usually follows that is a because statement, and the because is the evidence, or this is why it's important. So this is one of the ones we propose, that prehabilitation or exercise before surgery is important, and there's evidence to say that it's valid. So this first graph here is for total hip arthroplasty, and the bottom one here is for total knee. And we asked the panelists to rate on a scale of what, sorry, the pointer's so small, I'm going to use my finger, on a scale of 1 to 9, how important that measure is as a quality of, or as a measure of quality, and how valid the evidence is to support that measure. And the little asterisk there reflects the median, or the middlemost score. So you can see in this case that the panel mostly agreed up in the 7, 8, 9 rating that it was important, but there's a couple outliers that think it's less important, and I'm going to talk about that in a sec. With regards to validity, or is there good scientific evidence for this? Again, most of them up in this range, but again, a few out here who have different thoughts and different views. Similar results for the total knee. These are an example of the results for the acute care phase. So if a patient underwent a primary or first-time joint replacement, then the duration of hospital stay should be in a specialized unit award from specialized care providers. That's a process measure. And you can see there is much more variability here in the results for both the importance of that measure as well as the evidence to support it. So the median is down at 6, and if that continues to stay there for the final round, then that indicator will not pass, and they will not think that that's a valid or appropriate quality indicator. Okay? They have to rate a 7 or higher in the final round in order for the measure to pass. Show you quickly a couple more and then wrap up here. This is for the post-acute phase. So once they're discharged from hospital, if a patient underwent a primary hip arthroplasty, then participation in important life roles such as caregiving, paid and unpaid work and leisure activities should be documented, assessed and documented by a member of the healthcare team. So majority of people thought that that was important. Again, a couple of outliers, and we'll be exploring their perspectives and their comments, but less validity or less scientific evidence to support that statement. So we all know, and I know as the clinician, that's incredibly important, not just to measure whether you're strong or your knee bends 113 degrees today, but can I go back to work? Can I care for my grandchildren? Can I travel? Participation in important life activities. So we'll see. I'm hoping that this one passes in the final rating. And then this is a measure that reflects across the continuum, patient and family engagement. I can't stress it enough as a clinician how important that is, that patients and family be totally committed and involved in this process. This one has some criticism in the comments because it really has a couple of questions embedded in it. We were trying to get the list down to less than 81, but really this has 2 suggestions. One is about measuring a patient's attitude or engagement in the process, and this one is really about processes in place to help the patient and family feel motivated and feel engaged. We might end up having to split that one. And again, you can see the median score is fairly high at 8, but there are a few divergent views, and the same with the validity. So the next step in what the panelists are doing right now, actually I'll put that back up, is they are doing an online discussion forum this week. And they're discussing those outlier views. They're discussing why some of them disagree with that statement, and this is why. And then what they do is they look at their own ratings, and they look at what other people have said, and they reflect on what they rated it, what they thought, and they're going to re-rate them, all 81, because they all pass the initial cut point, and we'll end up with a finalized set of quality indicators that I'm hoping for logistical and practical purposes will be shorter than the 81. Then we're going to pilot test those in Edmonton, because my funding actually comes and research is through the Alberta Innovates Health Solutions grant at the University of Alberta in conjunction here with ARC. And the physical therapists in Edmonton are going to pilot test these for us. Can we collect this data? Are we the right people to collect the data? Is it feasible? That sounds great, but I have no way to get that information from my patient, and that's the feasibility issue, and that's important. And then the final and the most exciting step for me, where I'll be working closely with the Arthritis Patient Advisory Board, is to develop tools and products for patients, consumers, as well as clinicians, to help them put these quality indicators into practice. So those were funny statements, if, then, because. So we need to reframe those into a question, or if any of you have had a hip or knee replacement, you know you would have received this provincial booklet. I'd like to see those indicators be placed in there so you know what to expect and you know what to ask for with regards to quality of care around your rehab. Thank you. Oops. I'll go next. Oh, you're maybe in control now?
So we'll take questions now from the audience. So if you have any questions, just put your hand up and I'll bring the mic around.
Thank you. I know you said this was sort of focusing at osteoarthritis. What's the difference between that and the inflammatory arthritis when looking at total knee and hip replacement?
In terms of quality of care,
yeah.
A lot of the things will overlap. A lot of the processes should be in place, but the evidence supporting the various suggestions that I've made differs. People with rheumatoid arthritis tend to often have a bit longer hospital stay. So if any of these indicators reflect how long you stay in hospital, that will be skewed by the needs that people have if they have inflammatory arthritis. They often need more extensive rehabilitation because, as I said, it's one of multiple joints. They're at slightly higher risk for infection and perioperative complications. You're nodding. And so that would factor into what the sort of the standard of care is. So I don't want to try to lump their needs into this. And because 90% of hip and knee replacements almost are done for osteoarthritis, I thought I'd start with the largest body, but I definitely wanted to look at then, do these apply to people with rheumatoid arthritis? Pat.
Hi, Marie. I wanted to ask you about the time period of this. As you know, I'm part of your process, but it's been 4 years since my last of 3 replacements, five operations in total. And 4 years later, I'm still in private rehab trying to regain my mobility. So why do you think that 1 year post-op is satisfactory in order to determine your results?
That's actually longer than what most people receive, as you know, in terms of publicly funded rehabilitation. A lot of places will, after a hip replacement, for example, at UBC, you get a voucher for 3 physiotherapy visits, and that's it. Remember, this is Canada-wide. In other places, they get a voucher for 7 in Alberta. I'm trying to say rehab should last at least a year. I don't know what that looks like in terms of number of visits, and I'm not commenting on who should pay for that. But I'm saying the commitment to the rehabilitation process should be at least a year. But I totally agree for some people, at 1 year, you're still needing further recovery and rehabilitation and guidance. I'll be very happy if I can just get it to a year, though. But there's always exceptions to that and people that need ongoing care. What I'm trying to do is to get providers to realize we need to have something in place in terms of checks and measures and evaluation to see people out through at least a year. And I don't want people, Pat, as you've experienced sometimes, to fall through the cracks.
We have time for one more question.
It's all from this row right here.
I know it's obviously a lot of questions in this
Yeah.
row. This
I must
is
have made good eye
the
contact
nosy
with you
row.
guys.
I'm just curious as to what time frame you're looking at, Dr. Westby, in terms of when you hope this will move from the research stage to the practical
To the
application
implementation stage. So I'm hoping that they will start the final round of rating in about 10 days from now. Trying to, because they're from across Canada, it's challenging to, and everyone's so busy, it's challenging. So that'll probably take another couple weeks, and then those indicators will be in place. There's no delay really in starting to work with APAB if there's interest, the Patient Advisory Board, to start looking at how can we get those out to patients, how can we release the results. So I certainly think early in the new year that information should be made available, because the feasibility testing I spoke about is how easily can physical therapists collect this data from patient charts. This data isn't available in health records or databases. It's very individualized, but patients could know about this right away and start moving that into practice.
Thank you very much, Dr. Westby.